Dear colleagues and friends, I'm Maria Tsolia from the University of Athens, and my co-chair is Delaine Singadia, whom I'm sure you all know since he's the ESPID president. It is really a great pleasure and a privilege to welcome you to the opening session of the 40th annual ESPID meeting. This session is dedicated to the emergence and management of the COVID-19 pandemic. During the past 2.5 years, the world experienced a pandemic that as of today has costed more than 500 million cases and over 6 million deaths, while there are estimates that the true number is more than twice as high. We all know that beyond these numbers, the huge public health, social and financial impact remain to be estimated during the years to come. We therefore need to understand how could we have prevented this pandemic, or what could we have done better to mitigate its effects at an early stage? The answers to these questions are critical so that we are stronger and better prepared in the future and, if possible, make COVID-19 the last pandemic. The title of the first presentation is Mathematical Modeling and Pandemic Response against the pandemic, and I would like to invite Professor John Edmunds from the London School of Hygiene and Tropical Medicine to give this talk. John Edmunds is an epidemiologist with an interest in the development of mathematical models to help address public health decisions. To do that, he uses a mixture of mathematical models, statistical and economic analysis, but also sociological studies, trying to understand how people's behavior affects the spread of infectious diseases. I'm sure you have read some of the many scientific articles that he's written and also his interviews in the press. Early in the pandemic, he was among the first to foresee that the outbreak could be very serious, much more serious than we've had for many years. Dr. Edmunds.
Thank you very much. It's a real pleasure and an honor actually to be here giving this talk. So thank you for the invite. Okay, let's hope this works. Yes, so my declarations of interest, I don't really have any. These are the funders on the right help fund some of this work, and the people listed here help do some of this work, or did some of this work. My only declaration of interest really are, I'm desperate for these people to have happy and long careers. Okay, so I'm going to illustrate the use of mathematical models for COVID-19 decision-making. I'm going to use the UK as an example for a number of reasons. One, I work there. Two, the UK has used mathematical models for a long time to help inform public health decision-making in the vaccine field, for emergency planning and so on, and used them very heavily during this outbreak. And had a structure in place so that the modelling work done by many groups around the country could feed into government decision-making. That structure actually worked extremely well, but I'm not convinced necessarily the decision-making worked so well. So the net effect I'm not sure about. Here is the UK. This is the latest data from the WHO on estimated excess deaths from COVID-19 over the 2 years of the pandemic. And this is looking at countries across Europe, and the UK is sort of in the middle here, so we did okay. Despite the widespread use of mathematical modelling, we did okay, and I think it's a genuine question. Could we have done better? How much did modelling really contribute to lowering the risk of disease in the community? Could it have gone better or worse? And I'm still a bit too close to it to really answer that question, but I'd be really happy to hear from you in the discussion later. So just as a bit of context, this is just a look at the epidemiology in the UK. I'm just looking at hospitalisations here because that's been fairly well recorded throughout the epidemic, and so you can see the impact of the different waves of the epidemic in the UK. So the first wave, occurring as it did in most of Europe in sort of March and April, high numbers of hospitalisations at that point. That resulted in a lockdown, so I've marked the lockdowns here, lockdown 1, lockdown 2 and lockdown 3. So a very deep lockdown that was implemented in March the 23rd. Then there was a second wave starting in the summer and early autumn of 2020. which resulted in a second lockdown in November of 2020. I actually think most of the mistakes, or many of the largest mistakes, were made in the summer and the early autumn of 2020, but I'm going to gloss over that in my talk, but you can ask me later if you so wish. And then that resulted in a second lockdown in November, after which we noticed in some areas in the southeast of England there seemed to be a high number of cases, and then the genomic surveillance, which was working at that point and was extremely effective, picked up that that they all seemed to have a similar variant, and this became known as the alpha variant subsequently. That resulted in an enormous wave of infections, an enormous wave of hospitalizations in January of 2021, and a third lockdown, despite the fact that vaccines had started to be introduced. So vaccines were introduced in the UK in December of 2020, and it was rolled out from the oldest age group down to younger age groups over most of 2020. And the booster doses were also introduced again in the elderly, and then coming back down through the ages in the end of September, beginning of October of 2020. This was the Delta wave. There was an easing of restrictions that occurred here. The Delta wave that occurred in the UK mostly in the autumn of 2021 last year, and then Omicron hit with a very huge surge in infections in December of last year, and then this is the second wave of Omicron with the BA2 wave of Omicron. Cases are still coming down from that as we speak. So I'm going to just pick, I can't cover all of this, it's a huge amount, so I'm going to pick a couple of different time points and go through just a small amount of the modelling that was done at these different time points. So I'm going to take the early phase of the epidemic, so around here before this graph even starts, the first lockdown, the alpha wave here, the easing of restrictions after the alpha wave, and the third lockdown here. And then if I have time, I'll just say something quickly about Omicron in December of last year. So in the early phase of an epidemic, what are we doing? Well, initially what we're trying to do as a modelling fraternity is really, and epidemiologists, is trying to characterise the pictures. It's characterise the disease that we're dealing with. So we estimate some key quantities like the basic reproduction number, serial interval distributions, incubation periods, and so on, as well as case fatality ratios and hospitalisation ratios, the fraction of cases or infections that die or go to hospital. Then we want to sort of sketch out, with those information, we need to start to put those together and sketch out, well, the planning scenarios. How many deaths might we expect to see over what time frame? What's the peak height? The peak height being very important, of course, because that's the pressure on the health service. And then assessing the impact of early interventions, the most important being things like travel restrictions and contact tracing. I'm not going to talk about travel restrictions in the next slide, but we did do a lot of work on that. And then we start to look at the impact of other non-pharmaceutical interventions that might be put in place in order to control the infection. So just one slide, just whizzing through some of there was a large number of very important studies that were done, initially using the data from China on the contact tracing data. So that's the data up on the top left, for instance, looking at the incubation period distribution, serial interval distribution, as well as looking at the time between onset and hospitalization, onset and death. Those time delays being extremely important, because the hospitalizations that you see now are reflecting infections that have occurred 2 or 3 weeks ago. And if the epidemic is doubling, then you might and doubling every few days, then you might expect a huge surge in hospitalizations that's already baked into the system. So these delay distributions are extremely important to estimate. Anyway, putting those together, then we can start to make a model. So if we know those distributions, which we did start to know about in sort of late January, February of 2020, then we can start to put these together to look at a model. And this is an example of that. So for instance, this is just representing what might happen. So person A is infected, and then they develop symptoms at this point, and perhaps they infect individual person B and person C. These are the person B and person C. So they get infected at this point. They have their incubation periods and so on and so on. And if you know these distributions between infection to symptoms and infection to transmission serial interval, then you can then you can quite easily put a sort of simulation model together to look at these things, which is what we did. So Joel Helliwell and others did this, and looking at the impact of contact tracing. And there's a lot of information on these slides, but on all of them, this is the fraction of simulated outbreaks that are controlled. So you're looking to see whether you can control the outbreaks, have you got a high probability of controlling outbreaks. And in order to do that, then you need to contact trace an awful lot of the cases. So this is looking at different things, such as how many initial cases you might have, how much transmission there is before symptoms become apparent, and so on, the importance of subclinical infections and so on. All of which pointed to the same sort of results, in that in order to be able to control the infection, then you need to trace, to effectively contact trace a large fraction, 80–90% of the cases. And if you didn't do that, then you had a low probability of being able to control the outbreak. I think in the UK, this was possibly across Europe, these sorts of results were the attitude was, well, I don't think maybe we can do this, and so we'll need other measures in place. And I think perhaps elsewhere in the Far East, then their attitude was, well, we can probably contact trace 80–90%, and they certainly did. Moving on to the next step is to then put together the information that we have. When we're gathering this information, it's like having a jigsaw pieces and finding the jigsaw pieces and turning them upside down and being able to put a picture together of what the epidemic might be like. And to do that, we really then need a transmission dynamic model, and this is the one that we use. This is the structure. It's a kind of a classic SEIR structure, but we made a distinction between those who are subclinically infected and those who are clinically infected, because they may differ certainly in their behaviours, and also differ in their transmissibility. We were lucky in the UK in that we had data on how people come into contact with each other. It's a strange notion, but these things are spread by us coming into contact with each other. And so if we have data on these contact patterns, then we can help parameterize a model much better. So these are data, a little bit old at the time, but data that we had from the UK on contact patterns. So these are survey data. This is age of participants and age of the people that they contacted. And you can see that sort of young children and young adults make very high numbers of contacts, and they tend to also mix with themselves in schools and universities and so on. These off-diagonals are mixing within the household with different age groups. So we could start to put this together and look at different interventions, and these are different public health interventions that we looked at the time. This is early March of 2020. And all of these interventions, the top left looks at, and the red one is sort of no interventions, and came out with truly eye-watering, very scary results in terms of deaths up here, so perhaps 300 to 400,000 deaths in the UK alone if we just let the epidemic run its course. And that's, of course, without changing behaviour, which is likely, probably, the individual would have changed their behaviour anyway. But huge numbers of deaths, huge numbers of intensive care beds usage, so much so that, about 50 times we would require at the peak, somewhere around about 50 times as many intensive care beds as we actually had in the UK in order to cope with that surge in demand. So there was and all of these interventions, when looked at individually, really made very little impact in terms of the numbers of cases and deaths and the surge on hospital demand. So it's clear that we needed really stringent measures to be put in place. What we came up with at the time was to look at a background of having some public health interventions in place, some non-pharmaceutical interventions in place, and then an intermittent lockdown once hospitals' capacity, in fact intensive care capacity, started to be breached. And so the policy that we looked at here, this was in early to mid-March, was implementing these intermittent lockdowns in order to prevent the health service from becoming overwhelmed. And this policy did work at being able to prevent, it did reduce the numbers of deaths still to quite significant. We still would expect to have significant numbers of deaths, tens of thousands, perhaps even 100,000 deaths, which is a huge number. But we could manage to keep the demand on health down. Moving on, that was the strategy that we came up with, and in fact it was the sort of more or less the strategy that was followed in the end. Imperial College were working at the same time doing the same thing, looking at the same sort of interventions and finding similar sort of, so this is a famous Imperial College report number 9, also showing that the interventions that we were looking at, when put individually, really weren't sufficient to prevent overwhelming epidemic that would devastate the health service. We did go into lockdown on the 23rd of March, as shown on this figure down here. And you can see that compared with our European neighbours, we actually went in quite late, and we also implemented these other policies quite late. So it is a question, how much did the modelling really help? It certainly didn't help us move very fast here. In fact, I wonder whether, because we had these tools and the policymakers could ask us questions, well, what about if we did this, and what about if we did that, that might have actually contributed to us actually making a decision quite slowly, actually. And in fact, the speed of that lockdown was almost certainly the biggest contributing factor to the total numbers of deaths in the first wave. So this is a nice analysis by the Financial Times, just showing the numbers, the estimated lockdown day in terms of how slowly the numbers of infections there were in place when lockdown was put in place, and the total numbers of deaths or excess deaths in the first wave. And here's the UK right at the top. Okay, so that's some of the decision making and some of the modelling that went into the first wave. I'm now going to look to, at this point in time, which is when the alpha wave first hit us, which was just after the end of the second lockdown that we had in the autumn of 2020. And that resulted, as you can see, in a huge surge in infections. But we didn't know that necessarily at the time. This was just picked up as being an increase in cases that occurred locally in one part of southeast England, started to be spread, and from looking at the growth rate of that, what was then known as B117 virus and then subsequently became known as the alpha virus, you could estimate from the growth rate that this had a significant transmission advantage over the wild-type virus that was been circulating before then, to the order of about 50% more transmissible. And that this was consistent across different parts of the country, as you can see from this figure. That was extremely alarming, and putting that together, because of course at that time, if you remember just from the previous slide, we already had hospitals that were quite full. And to see this infection coming through was extremely alarming. So this then looked at different alternative strategies. We had started vaccinating, so at that point, but at the time we were vaccinating quite slowly, and it was quite clear, so this is now stepping up vaccination, it was quite clear that we had to step up vaccination very, very rapidly, but that wouldn't be sufficient to avert still a very significant wave, and that we had to put in place quite stringent measures in order to prevent an overwhelming level of infection in the health service. Unfortunately, just after that work was completed, we also noticed when we were looking at the analysis of death data that there seemed to be an excess in terms of deaths, and this then resulted in us looking using we had fantastic data in the UK, we still do have very good data, and we could link data across different data sets, national data sets, to come up with an enormous data set to look at the risk of death, controlling for different factors, but looking at the risk of death for those with the S gene target failure, which was a signal of the new variant, the alpha variant, and those that had a non-S gene target failure. And putting this all together in a Cox regression analysis, we estimated that there was about a 30% increased risk of death for the alpha variant compared with the pre-existing variant, unfortunately. So we went into a third lockdown, and then we started easing that lockdown gradually over the spring of 2021. And so I'm just going to give you a result or so on some of that. In fact, those lockdown steps, we went through a series of steps every month, easing the lockdown a little bit more, and models were used very heavily in order to inform each of those steps of the easing of the restrictions. I'm just going to show you just one quick result from the end of that process, which was July of 2021, and just looking at the impact that we thought we might have of the final easing of restrictions in July of 2021 in the UK. And these are just projections going forward, but with a couple of uncertainties, because the advantage of a model, of course, is that you can look at some of these and make explicit some of your assumptions about what might happen. And these are just looking at how people might continue or not to take protective measures, and how people might return to normal contacts. And if people return to more like that mixing before the epidemic, if they did that quickly, then we would expect to see a large surge. And if they were more cautious and changed their behaviour gradually, then we wouldn't expect a large surge in infections. And in fact, what happened? Well, we were measuring contact patterns every week in a large survey, 3,000 individuals selected from across the UK. And in fact, people returned to behaviour. This is the third lockdown. And people returned to behaviour very, very slowly and remained very cautious throughout the epidemic. And it's only, in fact, in the last month or two that individuals have really relaxed in the UK. They also continued to wear masks, even though they didn't have to a large extent. So that helped limit that spread of the epidemic, and I should go back, I don't know if I can. That helped limit that spread of the epidemic in the third wave, and you can see that the hospitalisation stayed at a fairly low level. In fact, at more or less the level that we expected it to if we'd have stayed at this low levels of contact. Then the Omicron wave hit us in December very fast, and we went through a similar series of trying to fit the model to the new data, estimate the growth rate, which was incredibly scary, and then try and project the impact of it of different booster doses using a fantastic model by Curry et al., which allowed us to be able to estimate what the impact of booster doses would be based on sort of neutralization titer. And putting that together, we ended up with sort of 4 scenarios, some of which looked not too bad in terms of... In all of the scenarios, we expected the numbers of infections to rise and to peak at much higher levels than we'd seen any time before in the epidemic, and indeed that's what happened. But in terms of hospitalizations, which is the red, or deaths in terms of the black, we expected those to be perhaps at the same height as the peak before, or perhaps slightly lower, and deaths somewhat lower. And in fact, what happened is we had hospitalizations peaked at a level at about half of the peak that we'd seen in January of 2021, and deaths slightly lower than that, because, of course, of the impact of vaccination. So I'd just like to finish up with a couple of slides just on the impact, so on the epidemic models and their use in decision making. So decisions in this context are made under enormous uncertainty. You have incomplete data, and one of the great advantages of models is that they can integrate evidence from multiple different sources and identify key drivers in terms of the epidemiology, identify knowledge gaps, and they can be used, therefore, and they can also be used to project forward as how many cases we might expect to see under different public health scenarios, different what-if scenarios. And that's really their main use. That uncertainty remains, it will always remain, but it can be reduced by fitting on your models to data, and I tried to show you 1 or 2 bits where we were fitting models to data, and by comparison of models to other models. And that was one of the great strengths of the system in the UK, is that there's many different models and a system whereby they were brought together and compared with each other, and so decision-makers could see the range of it that might be expected. Understanding so that models are reasonably good because our understanding of transmission is reasonably good. Our theoretical underpinning, which is actually the germ theory, is sound. And our quantitative understanding of the sort of epidemiological of transmission is improving through the social contact, through work, through improving data on sequences and much better surveillance data that we've had over the last 2 years. Of course, fitting our data to these, and that we've got better methods to fit our data to fit our models to the data. There are weaknesses, of course. One of the issues is that it's only one component in decision making, so the epidemiological models are only one component, and I wondered and I worried that we'd had too much weight. There is, there's of course an enormous economic impact from many of the interventions and other indirect impacts on psychological health and so on. Now, these in principle could be included, but in practice they were not. And they were not for many reasons. The link between cases and the economic impact is really unclear. The social and psychological impact of restrictions is still not clear, and it's certainly not clear ahead of time. So these things were not included. And I actually think, in many respects, it was a great failure of health economics not to really contribute to this field during the epidemic. Obviously, we can't include things that are unknowable at the time, so that would include the severity of Omicron. And accurately predicting behaviour, we could measure it after it had happened, but we couldn't predict it. And so that remains a major source of uncertainty. Do decision makers really take account of uncertainty, or do they just take the worst case scenario or the best case scenario, whatever fits their narrative best? I'm not sure. Do decision makers or the press understand the difference between forecasts, which are things of what we think will happen, versus scenarios, which are different things that could happen if? And I think in many instances, certainly in the UK, there was a willful misunderstanding of that. Finally, just what next? Well, there's still a transition to endemicity, so there's a continuing exit waves that all countries will experience. And many countries are still at considerable risk, China being a good example of that, because of lower levels of immunity in the population. We're going to have to shift to living with COVID, and we can use models and economic analysis to have some sort of rational basis. Should we be wearing masks? Shouldn't we? Should we be screening our healthcare workers, continue to do that, people in care homes? All of those questions could be asked, and models can help to come to a rational conclusion about those. We still really need to go back and work out what worked and why. There are almost no trials of non-pharmaceutical interventions, and models can be useful for making sense of multiple observations and data sources. And I think that we'll still have to stand by, because I'm sure we will be hit by other new variants in the next, I don't know when, and I'm sure we'll be needed, unfortunately. Whether we've got the manpower and the willpower to do it, I don't know. And I'll finish there. Thank you.
Thank you very much, John, for the excellent lecture. We're not going to take questions right now. We're going to proceed to the next presentation. And we have the questions all at the end.
Yeah, thanks. And just a reminder that the online people can submit their questions on the Q&A panel on the app, so they can do that. But it gives me great pleasure to introduce the second speaker, Dr. Kate O'Brien, who is attending, giving her talk virtually. Dr. O'Brien is Director of Immunizations and Vaccines at the World Health Organization, where she has been responsible for leading WHO's strategy for vaccination, including COVID vaccination. Today, Kate will talk about the emergence and management of the COVID-19 pandemic and lessons learned. So thank you, Kate, for giving this exciting talk.
Thank you so much, and I'm so pleased to be with all of you. Just disappointed that I can't be there in person. Can I just confirm that you can see my slides? I've shared my screen.
Yes, I think we can see your slide.
Excellent. Thank you so much. So what I wanted to go through with you is some lessons learned in a number of different domains, specifically around the current situation, surveillance, COVID vaccine, and resilience of health systems, and then where do we go from here? Before I get started, I'll just say that I have no conflicts of interest to declare. So 2 years on, the COVID-19 pandemic is really far from over. We have certainly a globally decreasing number of cases and deaths, but deaths are really region dependent. And you see on the left-hand side the case counts in the bar chart, the deaths in the line graph. And on the right-hand side, some examples of two regions, the Wipro region and the Euro region, where in this latest wave, we see a very substantial increase in cases, but two different patterns of the deaths. And then in the bottom, we see the current situation in South Africa with what looks like another wave beginning, and we will find out how far that goes. Now, COVID-19 has had a devastating effect on societies. I don't think anybody in the room doesn't know that. There's been about 90% of healthcare systems have expressed some significant disruption, over $16 trillion in estimated revenue losses internationally, about 1.6 billion students out of school, and a reduction of about 30% in investments in clean energy transition, and people pushed into poverty. Over 135 million more people expected to be in poverty by 2030. On the right-hand side, you see that this economic impact far outweighs any previous outbreak, with the global annual economic impact of HIV, TB, and malaria shown as the horizontal line, and various outbreaks over the past 2 decades demonstrated. At the current time, countries are really facing different situations, challenges, and scenarios for ending this emergency phase and for achieving some sort of sustained COVID-19 control. We have current and previous strategies. There's a shifting epidemiology. Population demographics and risk factors are variable. Population immunity from vaccination and or infection variable, as well as access to life-saving tools and capacities to implement in communities and across all of the pillars of vaccines, therapeutics, diagnostics, and the health systems to deliver them. This operational readiness and agility to adjust actions and surges as needed, also very variable. And probably most importantly, public trust, societal engagement, and unrest. Now, from a WHO perspective, and WHO serves as the lead agency from the health sector of the UN, we have had 3 iterations of a strategic and operational preparedness and response plan, and I'll show you just on the right-hand side the current version, which is in force right now. And in that version, the strategic objectives to end the pandemic as a public health emergency in 2022 have to do with 2 things. First is reducing and controlling the incidence of infection, and secondly, preventing, diagnosing, and treating COVID, and reducing both of those things, reducing disease morbidity and mortality, and protecting individuals is the focus of the strategy. I think it's also important to say, as John did, that we've issued a revised number of excess deaths that are associated with the pandemic on May 5th, and that new estimate is not obviously the measured estimate that comes out from the surveillance, but is a modeled estimate of 14.9, almost 15 million excess deaths, which expresses this differential and excess mortality associated with COVID-19 in both direct and indirect deaths. So that's the current situation. I want to jump now to sort of surveillance, the laboratories, and public health intelligence. And we all know, as John very eloquently was describing what happened in the UK, waves of different variants coming through. We can see that picture of the waves in the top figure. But there has also been, on the bottom figure, which is the bar chart of the number of sequences that have been submitted to GISAID, which is how we know largely about the burden of these variants. There's been a substantial decline, as shown in those bar charts, in the number of cases that are being reported to GISAID. So this reduction in testing and sequencing really impairs our ability to understand how the virus is evolving and the impact that that evolution has on public health. So this is the sequencing capacity, and the testing strategies really differ across regions and countries. So it's quite difficult at times to make interpretations of exactly what's happening globally or by region. On the issue of variants, we do have a set of advisory groups that inform decisions about variants of concern. And I just want to illustrate here how WHO sort of monitors these situations and responds from a policy perspective. And it really is a lot around the virus itself, the vaccine products through research and assessment, and then the vaccine use through policy. And so 3 critical external expert advisory groups on virus evolution, on the composition of vaccines, the TAG COVAC, and then SAGE as the policy entity for vaccine use. So I want to focus on COVID vaccine because it's been so much at the heart of efforts by countries to end this pandemic. And this figure shows the years from the first available data across many different vaccine antigens, and then the coverage globally. And you can see here that there's absolutely no question about the fact that COVID-19 introduction has been the most rapid rollout of any vaccine ever, with over 11.7 billion doses of vaccine having been administered as of yesterday, Monday. And there are now 10 products that have achieved WHO emergency use listing that are shown on this slide here across 4 platforms. And obviously this reflects an extraordinary achievement in the science of vaccines. These WHO EU-eligible products have achieved regulatory clearance in over 3,000 authorizations around the world in this short 1 and 4 month period of time, across dozens and dozens, in fact, hundreds of countries, and a set of aligned processes to get products through regulatory authorization in the fastest possible time. And so I think this has been one innovative area that has been like none before. And I think it's important to remember that before COVID, there was only one vaccine that had ever been emergency use listed before, and that was the novel oral polio vaccine, which was emergency use listed in the 2 months prior to the COVID pandemic hit. So we do have a strategy to achieve global COVID-19 vaccination. It was issued last year. And it specifies a series of goals around reducing mortality and severe morbidity and hospitalization as the first goal, and then advancing to the resumption of most socioeconomic activities, and finally a third goal of reducing transmission and future risks. And across that trajectory towards full recovery of our communities and societies, there were a series of tactics or steps that were a series of priorities of which groups should be vaccinated first. And in the bottom figure, you see the SAGE roadmap that was issued as a second version, version 2 of the roadmap at the beginning of this year, that looks at the highest priority use groups down through to lowest priority use groups, and really specifies who's in those groups and the importance of the booster dose as part of a full vaccination schedule. And this 70% coverage target of the world's population that was part of the strategy is really about specifying what's on that tactic area. It's about all adults and all adolescents. In other words, a population-based strategy to achieve both substantial health returns, further reduction of disease burden beyond those of the highest priority group, catalyzing political will for at-risk investments, and strengthening primary health care. And I'll go a little bit into where we think the achievements have been against this strategy. It is a living document, and it was specified that it would have to have country adaptation. So given that there was a strategy, there were products, what has been the performance of those vaccines? And I'll specify that against Omicron. So there are 67 studies, given that Omicron is the variant that is around the world right now, 67 studies that evaluate the performance against Omicron across 6 vaccines, which represents 3 of the platforms. The 4th platform, the protein vaccines, we have no assessment. And the major takeaways, I certainly am not going to go through the 67 studies, but in aggregate, the primary series certainly has vaccine effectiveness that declines over time for all products, especially against symptomatic disease and infection. Booster doses increase the vaccine effectiveness against not only the severe disease end of the spectrum, but in fact, all outcomes. And booster dose effectiveness against that severe end of the disease spectrum is very high. It's above 80 to 90%, depending on which study and which product. And that is substantially higher than the VE against infection and clinical disease. Now, we have to acknowledge that we do have limited data on boosters for some products. So what's changed since the launch of that strategy? There are really 3 areas where The pandemic has evolved, the vaccination programs have evolved, and the demand-supply balance has evolved. Again, I won't go into detail about all of the different aspects, but I mostly want to emphasize that there has been, on the epidemiologic side, worldwide infection-induced immunity, in part due to the fast spread of Omicron, and certainly a measured morbidity and mortality burden that is lower in some countries that are still far behind on their coverage. So still some evidence that infection-induced immunity is having some effect. On the vaccine performance side, we now have vaccines that are highly effective against severe disease, but have limited protection against infection and reduction of transmission. And so that right-hand side of the strategy, the implications for the goal of reducing transmission through the use of vaccines, has some weakening in the evidence around how effective vaccines can be to achieve that goal. We also have some questions about long COVID and complications of COVID and vaccine safety, so that there are trade-offs that countries are starting to make, and we're starting to see that very much on the demand side of things. We now are in a situation where supply is abundant, and yet countries are struggling to maintain political will in the face of other health system priorities. And so I just want to show you that in contrast to 2021, where the world was in severe supply constraint and was really what drove the inequity in vaccines, we are now in a situation of ample supply. So this just shows the total available global supply, both from the COVAX facility in dark blue and the non-COVAX supply in light blue across income strata. And the horizontal bars show you how many total doses in that income strata would be required to achieve a 70% primary series coverage, and how many doses would be required to achieve 3-dose coverage for all people over 12 years of age. So you can see that in aggregate, the world has enough doses. They're still not in the places by various contracts where it would fulfill the total requirement for a 3-dose regimen, but certainly in every income strata, a 2-dose regimen in everybody above 12 years of age has contracted ample supply. And now this figure just shows you where doses have been shipped already. The previous one was both shipments and contracts. And here we see that of the total doses that have been shipped, the low-income countries are highly dependent on the COVAX facility, as are low middle-income countries. This has been the mechanism to assure that countries without the means to secure those contracts themselves have had access to vaccine. Now, vaccine manufacturing is another issue of equity, and this map shows you the location of COVID-19 vaccine manufacturing. You see quite a gap in the Africa region. In fact, if this is as of today, and if we had shown this map at the beginning of the pandemic, there was no manufacturing on the African continent. And so, again, a very important equity issue, because it's arguable, I think we can argue, that part of the inequity in the distribution of vaccine was most strongly felt in the one region that didn't have manufacturing. And so there is now an mRNA technology transfer hub program that's been established since almost a year ago to provide that technology globally. And that hub has been established in South Africa with countries in different regions around the world that are the spokes of the hub and will be receiving or are already or will be receiving training in the South African hub and the know-how to stand up biomanufacturing in their own country. So what does this all mean from an equity perspective? Well, 59% of the world's population has been vaccinated with a primary series at this point, but there are significant disparities in between regions and income strata. And here on this slide, showing in dark blue the share of the population vaccinated with a complete primary series, and then in light blue, the additional fraction of the population who have been partially vaccinated, you can't help but see that the Africa region on the left-hand side when looked at regionally, and low-income countries on the right-hand side when looked at by income strata are the groups that are clearly very far behind. However, when we look at advanced market commitment countries. In other words, countries who are getting their doses from the COVAX facility and those countries that are getting their doses in other ways. The AMC countries are not as far behind as one might have thought they would be. So the AMC has certainly functioned in a very strong way to catch up that inequity. Most importantly are the healthcare workers and those over 60 years of age, the two highest priority groups. And here, looking at coverage in both healthcare workers by income strata on the left and those over 60 by income strata on the right. Again, we see that healthcare workers are very highly covered by income strata, except in the low-income countries where just under 40% have been fully vaccinated. But an even more stark story is on the right for those over 60, the elderly. And we see, again, in low-income countries, not even a quarter of older adults have been fully vaccinated. So the scale up of delivery to reach that 70% target in service of the three goals that I showed you in the strategy means that a scale up of pace of vaccination would have to happen very quickly. This map shows you the fold increase that would have to take place in order to achieve that 70% coverage of a population by the end of June. And in order to support the acceleration of vaccination, there is a vaccine delivery partnership that consists of WHO, UNICEF, and Gavi, with one support team for countries and a focus on 34 low coverage countries. These are 34 countries that were below 10% at the beginning of January. And the delivery partnership uses four main levers to support countries: political engagement, funding for actually deploying vaccines, specialized technical and assistance and surge support, and assistance to countries in their demand planning. And so just to give you the list of these 34 countries that were prioritized at the beginning of January. Again, these are the countries that were below 10% coverage at the beginning of January. 16 of them, shown on this slide, have reached over 10% by mid-April, and that's the red arrow with the number 1. So this is the coverage, the full population coverage by mid-April. And under number 2, you see the fraction of the over 60-year-old population that's been vaccinated. And as you cast your eye down, you'll see really big differences in the fraction of the population over 60 that's vaccinated, indicating that the strategy that countries may be using is not potentially targeted towards the highest priority groups. And similarly, if you look at the proportion of the healthcare workers who are vaccinated, a similar picture, although a little less dire than the over 60s. On the left-hand side, next to the countries, you see 4 countries that have sort of dark blue dots next to them. These are countries that have significant humanitarian situations in the country. And I wanted you just to remember that part of this slide as I go to the next one. So this slide is the 16 that have reached over 10% by mid-April. And this is the slide with the 18 countries that still by mid-April are below 10% coverage. Please notice how many of these countries are dealing with significant crisis such settings or humanitarian settings. And also as you look to the coverage that they have right now, as well as their coverage in over 60s and their coverage in healthcare workers. So in addition, I want to just speak a little bit about demand. This has been so important and probably one of, now that we are in a situation where we're in a supply replete environment, it's really about demand at this point. And we've had a huge set of learnings about behavioral sciences, infodemics, and other characteristics of demand, which is regularly understanding of barriers to uptake is critical. They change over time. Listening and engaging communities, both online and offline. Lessons on the importance of political commitment, and I cannot overstate that. We have example after example around this. The added attention and investment in behavioral sciences has been really key for communities and countries to understand what direction to take to address behavior, to address the demand issues. And I think it's very fair to say that data on hesitancy have shown that hesitancy is not the main problem, which is quite a contrast from where the immunization world was in 2019 before the pandemic hit. We also have learned that if there are going to be mandates around vaccines or any other intervention, to do that with care, to make it fair and justified. And then we have 5 trends that have been identified around infodemics, largely around that we cannot monitor closed messaging apps, that there is a lot of imposter content that is portraying itself as being from legitimate institutions when it's not, that misinformation and hate speech intersect with each other. These are not distinct areas, that videos and memes are getting more influential as they look more and more professional, and that conspiracy theories are moving into the mainstream and in some places are part of the mainstream. So just to 2 additional topics and lessons, the resilience of health systems in the pandemic. And I have many examples of this, but given this audience, I thought I would focus on the disruption in services for immunization that are distinct from the COVID-19 vaccine. So on the left-hand side here, this is data, in fact, both data from both sides is from an iterative survey that is conducted by WHO on essential health services. And this is from the 4th quarter of 2021. So you see that about 50%, 48 and 49% of countries are reporting disruptions still in their routine facility-based immunization on the top and their routine outreach immunization services on the bottom. So almost half of countries are reporting these disruptions still at the end of 2021. On the right-hand side are the percent of countries that are reporting disruptions to routine immunization services as a result of the COVID-19 vaccination scale-up. And what you see here is that scale-up of vaccination services were most frequently reported to disrupt outreach interventions for other vaccines, about 49% of countries, as well as disruptions to school-aged children and adolescent services. So very significant disruptions, both because of the pandemic on the left and because of the COVID vaccination program on the right. And campaigns, which are a really crucial part of many, many countries' immunization program, have been disrupted around the world. So on the left, there were 66 countries in May of 2020, so at the heat of the pandemic, with at least one campaign that was postponed. And yet, if you dial forward a year and a half, so in January of 2022, there were still 37 countries with at least one vaccine preventable disease immunization campaign that was still postponed, meaning we have a huge accumulation of children who are missing life-saving vaccines. So where do we go from here? The first is that we have to embed the lessons and the innovations that have been accrued through the whole period of COVID into routine programs going forward. And there are 3 here that the Immunization Working Group on Innovation focused on at the outset of the pandemic. And I'll just focus on 3. One is on micro-planning. GIS technologies we know are highly effective at helping countries plan. And there are over 15 additional countries that have now embedded GIS mapping tools in their routine program. The second one I want to talk about is vaccination status. There's been a long issue of household carried documentation of vaccination status or of facilities knowing the vaccination status of individuals. And we now, most people in the room, I'm sure, have a digital vaccination certificate. Again, these are being embedded in routine programs. And the third is around health worker training, which has been expensive and labor intensive. We now have trainings that are adapted for adult learning through SMS and WhatsApp and Moodle messaging deployed in now dozens of countries. So as what next? Well, we're also looking at scenarios. Where is the pandemic going to go from here? So we've laid out 3 scenarios, a kind of base case scenario where the virus continues to evolve, with decreasing severity over time because of sustained and sufficient immunity against severe disease and deaths, but with periodic spikes in transmission in cases of waning immunity, and then a potential need for periodic boosting. That's the base case that we're operating against. We've also laid out a worst case and a best case scenario, and we will find out where frankly this virus is going to go, and how the virus is going to operate that will drive us against either worst case, best case, base case, or somewhere in between scenarios. And not all countries are probably going to be in the same place. So I think we have to recognize that health emergencies begin and end in communities. They start with a patient zero. They move into local, national, regional, and finally global outbreaks. And they do require a systematic approach to achieve health protection, beginning with a resilient national and local public health service that is tightly integrated with primary health care and communities with trust. And that's supported by global and regional networks of health emergency preparedness and response systems and partners. Now, there have already been many reports on this topic and on this pandemic, and we won't, of course, go through these. But going forward, we do need to address the system gaps that have been highlighted by many of these reports around governance, around systems, around financing, and these drive towards equity, inclusiveness, and coherence. We've laid out a readiness of critical interconnected health systems, which are central to health emergency preparedness and response, that need to be bolstered. And each of these elements, collaborative intelligence, in other words, surveillance, community protection, including vaccine programs, clinical care, and countermeasures, both the research and the access to countermeasures, are the four building blocks around emergency coordination. And so I'll just end there by highlighting that at the World Health Assembly, which will take place at the end of May, there will be a very significant discussion around global health architecture for health emergency preparedness and response. And I think, as the Director General of WHO said, while science delivered, politics too often triumphed over solidarity in this pandemic. And we hope that as we build towards the future, this will be in a different place. So I'll stop there. Thank you so much.
Thank you, Kate, for that very comprehensive talk. So we'll start with taking questions. Just remind the on-site attendees that if you go up to one of the mics in the room to ask your question, we've also got online questions being asked. So I don't see anyone standing up yet, so maybe we can start off with the first online question.
We can start. We have a couple of questions for John. One is from Olivia Swan. Excellent talk. How do we build risk literacy into our societies to be better prepared for next time? Haven't we, to some degree?
I think we have.
We were trained. Everyone.
Yeah, I think we have improved. I think it's a really good question because it doesn't just address. It goes way beyond COVID, of course. But I do think that we do need to improve that. I do think that. I think we did improve. I think people did understand that that there are risks, that there's nothing black and white, that there is, and I think that people took on board what was asked of them very well and responded incredibly well over the course of the pandemic. And so I think that there is something to build on. I really do. I think that I showed one slide from the Financial Times, for instance. So I think some of the visualization of data that was done in the media was superb. Not all of it, but much of it was very, very good. So I think that there's a lot to build on. I think we've gone through a process. I'm confident that we will get better over time. But it comes into all kinds of public health decision making. It should be done much more widely, of course.
Do the models become better? Do the mathematics and the modeling improved? And did the people's behavior improve? I mean, people are trained so that if hopefully will not be needed, but with the next call, will they respond better?
I'm still amazed at how people did respond and how well they stuck to the guidance, even when they didn't have to. So certainly in the UK, the government was very keen to drop all legal restrictions as fast as they could, and yet people remained cautious for good reason. They remained cautious during that Delta wave for good reason. There was a lot of people going to hospital. There were still significant deaths occurring, and so I think that people really did help. The public generally really did keep a lid on the epidemic and help negotiate a way out of it better perhaps than the politicians at times. Did the models improve? Yes, they always do. What happens is that models are a combination of assumptions and data, and at the beginning you have to use a lot of assumptions because you don't have the data. And as time progresses and you fit the models to more and more data, then your uncertainty shrinks, and your model is now being driven not by the original assumptions, but now being driven primarily by the data. So yes, the model has improved, partly because as well the data improved. We went from night to day in terms of data in the UK, but right across the world actually, and the availability of data, the testing that was put in place right across many different countries. And I'm leaving out actually many low-income countries that really stayed in the dark, and so we have very little information about what happened there. But in most high-income countries, we went from almost no information about what the epidemic was going to really superb information. I hope we never go back.
I think we have a question up in the audience. Shall we?
Okay.
Gentleman at the top, would you like to ask your question?
Yes. Thank you. This question is for Dr. O'Brien. This is Ghassan Dibabo from Lebanon. How will the WHO decide on updating the current vaccines? The virus has accrued a large number of mutations in the spike protein, which is the main antigen in most of the vaccines. And we've seen the vaccine effectiveness gradually slip. What would be the criteria to decide on updating the current version of the vaccine? And is there any concern that the virus will revert back to an older variant or acquire the mutations that were in Delta or Alpha that caused a more severe disease? Thank you.
Yeah, thanks for a great question on this. There is, as I showed on one of the slides, there is an external expert group that is advising WHO called the Technical Advisory Group on Composition of Vaccines for COVID. And this is a group that has been in place for almost a year, that has been working very deeply with the virologists on the genetics of the changes in the vaccine, their relationship to the performance of vaccines, both in relation both to immunogenicity and to actual real-world performance, and the monitoring of variants as they are emerging and as they are behaving epidemiologically. The TEG-COVAC has a framework that they're working with to provide advice on what the composition of the vaccines should be, and whether or not there should be changes in that composition. And one of the primary pieces of evidence is the performance of the vaccines against the severe end of the disease spectrum. And as we looked at, in some of the slides I showed, is that performance is holding up quite well, but that there is more performance that could be, people believe could be achieved, especially on the more mild end of the disease spectrum. So there's a series of criteria that they have established to look at that is not, it's not a cookie cutter. It's not as if you can just sort of add up criteria and determine. And I think some of the biggest questions for them are exactly as you described, that in understanding how vaccine manufacturing works also, by the time a recommendation was made, and when would the vaccines actually be available for deployment? And should they be vaccines that layer on top of a primary series as a specified multivalent or variant-specific booster dose, or should they be around primary immunization? So those are some of the criteria, and I do expect that they'll be coming out. They've had 2 or 3 reports now, and another report will be coming out in the near future.
Okay. We'll go on to the next question. Any other comments?
We learned that cloth masks are significantly inferior. I'm interested in what we learned about masking as a prevention, spacing, school closing, and how those opinions or theories evolved over time, because it seems, as you said, we have very little clinical trials at which to judge how those really worked and how to use them in the future if we should need to.
I think it's an excellent point. So yeah, most of the non-pharmaceutical interventions were not subject to any trials whatsoever. The only ones that were, the main one was mask. There were 2 trials for mask wearing, one of which was underpowered, small one in Denmark in the first lockdown, an individually randomized trial and didn't really show much effect. And the second one was a large cluster randomized trial in Bangladesh that did show an effect of mask wearing, but that was mostly in rural Bangladesh, where it went from 0 mask wearing to quite high levels in those villages that were given masks. So, and a cluster randomized trial, you'd expect to have a kind of indirect effect as well, if there is an effect. So, not much information. All the other non-pharmaceutical interventions really were left looking at the data, peering at the data and trying to work out whether they did work by making international comparisons, for instance, or just before and after type things. But before and after are fraught with difficulties because usually there were so many interventions that were put in place all at the same time that it's extremely difficult to do. There are some efforts. I actually showed one slide. There have been some efforts where I tried to unpick these things by fitting models and statistical models to the data and using these international comparisons. But I think there's a huge there's a lot more work that could be done. But I really think the thing to do would be to put trials in place right now. As we're scaling back these interventions, put a trial in place. We have very high prevalence. We still have very high prevalence with the Omicron wave right across the world. So trials could be powered very rapidly. There are issues about equipoise. You know, in the UK, we've got rid of these restrictions, and so I think it's genuine that you could put these. You could do a trial, whether it's on mask wearing or whether it's on testing people going into care homes. You know, visitors to care homes or staff in care homes, healthcare workers. All of these could be subject to clinical trials and just isn't being done. And I find that I think it's a failure. I think it's a failure right across the board of our profession, whether it's epidemiologists or infectious disease specialists, right across the board, to subject these interventions to proper proper clinical trials. It hasn't been done. We can still do it now. There's time, and we should do it now.
Maybe easier now.
Thank you. I think Steve Black has been standing up for a while. So do you want to ask your question, Steve?
Can you turn on the microphone?
Okay. Hello?
Yeah, we can hear you now.
Okay, sorry. Kate, this is Steve Black. I have a question for you. One of the disparities you didn't mention is the disparity in how vaccines have been evaluated. The mRNA vaccines have been evaluated extensively in high-income countries. The AstraZeneca vaccine and the Johnson & Johnson vaccine have been evaluated extensively. But we've know virtually, and significant safety issues have been identified, but we know virtually nothing about most of the Chinese vaccines in terms of we're learning about their effectiveness now indirectly, but really in terms of safety, there's really not been effective monitoring, and the same thing is true for Sputnik. So what do you think needs to be done for the next pandemic differently in terms of how vaccines are evaluated globally? Thank you.
Steve, first of all, it's great to see you. It's such an important question, and it's vexing. It's a really vexing area. So you're completely right that the differential between information that we have on real world performance, real world effectiveness is quite high differential across different products. We do have information on the inactivated vaccines, largely coming from South America, but not only. And we have much less information on certainly the Sputnik product, and no information on the protein vaccine. And so I think the biggest issue here is that we have this disconnect between the evidence that is required for regulatory authorization and the evidence that is useful for policy and for optimization of assessing both performance of vaccines and therefore optimization of vaccine programs. And we have very few levers for actually asserting the need for that kind of information. I think probably if we were to say, what would be the best thing if we could have a magic wand and if we could change this, what we've been able to do is at least get the funders together in a funders forum to identify both a preview of where the data gaps are. But one of the most challenging things was it was really hard to set up studies for particular products because we didn't know where those products were going to be, nor when they were going to actually be distributed and actually delivered. So that the link between availability of vaccine and so global access to product by product, and then the establishment of the studies in advance and obviously study sites that could do those evaluations was really challenging. And the only thing that I can imagine that would improve this over time is there was no source of centralized funding that could then be strategically deployed as we understood more and understood it early about where the vaccines were going to go in which period of time. So if there was some funding bucket that could be strategically assigned and aligned to where funding was going, where the gaps were, that would be a mechanism to establish better evidence on a product by product and a geography by geography basis. I think this is a really difficult area. It's not constrained to COVID vaccines. It's the same gap over and over for products, just about every vaccine product.
I think time has finished. I see Sam is there. Yeah, one last question.
I think the mic it's working.
It's on now.
Shomesh Ladani from London. Hi, John. Good to see you in 3D. I have a question for you. As pediatricians, we've been really worried about the health of the children because they were disproportionately affected by the virus in a good way. And one of the big questions that keeps coming back to us is this balance between some people thinking that we didn't close school enough to stop transmission, while others were thinking that we shouldn't have closed schools at all. So my question to you really is, what did your models tell you about the impact of school closures on community transmission? And what did the real-world data show after that happened?
Well, it's mixed. I think we expected the schools to have a bigger impact than it probably did. School closure probably did. We never expected school closure to have a big impact because for lots of reasons. One, in our countries, high-income countries, there's not that many children compared with adults. And unlike influenza or something like that, susceptibility was spread right across all the age groups equally. Everybody was susceptible, which isn't the case with flu, where susceptibility is concentrated in young children. Also, the serial interval was much longer, so things like that would make and children clearly didn't spread the virus as effectively as others. That others did. But it's wrong to say that they didn't spread the virus. They did. And we were lucky in the UK, or not lucky actually, there's no luck involved in it whatsoever, but in the UK we set up a very large-scale household study the ONS study, and there it's quite clear the role of children bringing infection into the home, even though it's mostly subclinical, and then spread from there within the home. So it does play a role, but it's on its own, it would never be sufficient to hold infection down or anything like that. It's quite a small component of overall. So I think occasionally we had to use it. I do think with the alpha wave we were overwhelmed, and I think we had to use it then. We probably didn't have to use it at other points in the epidemic.
Okay. We can't hear very well.
Now? Okay, sorry. I was just going to say that this is really, really important, because I think in the beginning when we didn't know, it was right perhaps to close schools early because we weren't sure about transmission. But now that we have that information, that messaging is still not out there. And I think we need to do better as a community to emphasize the lesser role of children compared to what it was. I don't think anybody believes that children couldn't transmit or get infected. But the idea that schools are contributing to community transmission is still out there, and I think we can all do better to try and get the message out there. Thank you.
Yes, I think it has become clear that schools do not contribute that much to. It has been. I don't know if you agree that they have a major contribution to.
I don't think because this is such a widespread infection affecting everybody in society, just closing one aspect is never going to do things. So just closing pubs, for instance, was never going to stop the epidemic on its own. Just stopping the football, people going to sporting events, was never ever going to stop the epidemic on its own. Closing schools, again, wouldn't stop the epidemic because the vast majority of people don't go to school. So, you know, in order to have an impact on such an epidemic like this, you have to layer up all of the restrictions. It's a really horrible fact, but if you want to bring the reproduction number from you know, whatever it was to below 1, then you have to have a layer upon layer of restrictions all on top of each other. Individual ones won't work, and that it goes for a school closure or any other sector that you might want to take.
Thank you all very much. Thank you, the speakers, John and Kate. Thank you very much. And the audience for the great participation. The discussion can go on outside, I think. Thank you.